Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Trends and Variation in Use of Breast Reconstruction in Breast Cancer Patients Undergoing Mastectomy in the United States by Reshma Jagsi et al. My name is Lindy Vanderwald, and I am staff breast surgeon at the Baptist Cancer Center in Memphis, Tennessee, United States of America. My oncologic specialty is surgical oncology. The NSABP B06 trial, published over 25 years ago, and subsequent trials conclusively showed no difference in survival outcomes between mastectomy and breast-conserving surgery with radiation. Recent data suggests that breast-conserving surgery may provide better outcome than mastectomy. However, the proportion of women treated with mastectomy is paradoxically increasing, along with a rise in prophylactic mastectomy of the unaffected breast. Reasons for this trend are unclear. One factor making mastectomy more palatable and a possible driver of increased rates of mastectomy is access to breast reconstruction. Jagsi and colleagues evaluated the rate of reconstruction in women with breast cancer undergoing mastectomy in privately insured working-aged women. Using commercial claims data, 20,560 women were identified who had undergone mastectomy for breast cancer between 1998 and 2007. Reconstruction increased from 46% in 1998 to 63% in 2007. Reconstruction correlated with plastic surgeon availability, as well as with geographic region, patient age, and use of bilateral mastectomy. We commend the authors for their methodical approach to analyzing these data and for recognizing some of the serious pitfalls. Most significantly, the cohort expanded dramatically with additional health plans in the middle of the study period, approximately coincident to the time point when increases in the reconstruction rate were noted. Also, the generalizability of this data may be limited, as these are mostly women with insurance and with over 2/3 in the two highest quartiles in income. Age affects the use of breast reconstruction. Among women over age 65, reconstruction rates are reported as low as 6% nationally. Though older women may decline reconstruction for personal reasons, we must highlight that there is no evidence of increased complication rates in older women undergoing breast reconstruction. Older women should be offered breast reconstruction based on their overall health status and perioperative risk assessment. Treatment also varies by health system factors. While the SEER report showed an average reconstruction rate for women over 65 of 6%, the rates at individual institutions ranged from 0 to 44%. Similarly, rates of reconstruction at NCCN institutions for similar patients showed wide variation. This highlights that patient care may be driven by regional culture, resources, or provider biases, as reflected by an institution's practice. The type of reconstruction used also varies, potentially related to provider bias and interest in the use of autologous tissue flap reconstruction. While in many cases, flap reconstruction provides superior cosmetic and longer-lasting results, its use is declining compared with implant reconstruction. Flap reconstruction is used more commonly at large or academic centers. Staffing limitations in private practice settings, where there are often no trainees or other readily available assistants, for the labor-intensive flap techniques, and relatively lower reimbursements rendered for these lengthy and complex procedures may drive this trend. Plastic surgeons are incentivized to perform implant-based reconstruction, with reimbursements ranging as high as 6 times higher than that for flap reconstruction based on intraoperative hourly rates. However, while physician payment may be lower, there are data to suggest that health system-wide cost effectiveness in the long run may favor flap reconstruction. Another finding of Jagsy et al. Is the increased use of contralateral prophylactic mastectomy and associated higher rates of implants. Other studies have shown similar results. These two findings are likely related, as bilateral autologous flap reconstruction is a long procedure with substantially prolonged recovery compared to implant techniques. Additionally, a reason cited to support contralateral prophylactic mastectomy is that achieving breast symmetry may be difficult with a single implant compared to the contralateral native breast, whereas symmetry may be more readily achieved with implants when both breasts are reconstructed at the same time. Many women electing contralateral prophylactic mastectomy have early-stage disease and are candidates for breast conservation, but they select mastectomy for the treatment of the affected breast. This is despite the absence of evidence of any impact on survival from the ipsilateral or contralateral mastectomy. The only exceptions possibly including women with known inherited genetic susceptibility and young women with small hormone receptor negative cancers who account for only 5 to 10% of those with breast cancer. Operative risk is higher with contralateral prophylactic mastectomy, with the risk of complication rates in the prophylactic breast as high as 27%. The reasons for these choices are not clear, but ultimately the affected woman, not the surgeon, should make the final choice. In a population-based survey, the primary reasons cited for choice of mastectomy was surgeon recommendation, patient choice, and failed breast-conserving surgery. Factors affecting patients' choice include attitudes, advice of friends and family, the fear of recurrence, and a perceived survival benefit. Media portrayals of celebrities undergoing prophylactic mastectomy with plastic surgery reconstructions reduces any stigma of this therapeutic choice. How and by whom a woman's options are presented may impact choice. Women may overestimate their risk of poor outcome, just as they often overestimate their risk of breast cancer. This highlights the importance of effective communication between the patient and her clinician. However, physician bias may influence a woman's decision, and physicians may not fully listen to or understand patient preference. Women who are given a treatment recommendation by their physician, rather than a discussion of options, report low involvement scores in a shared decision-making process. Interestingly, women who take a greater role in treatment decisions are more likely to undergo mastectomy. One strategy to enhance communication with patients is to involve non-physician staff in patient education. Evaluating a woman's learning and information needs prior to consultation may reduce barriers to communication. Another method to more fully inform women is to use decision support tools. These paper or electronic tools highlight pertinent aspects of treatment, including fear of recurrence and risk of contralateral disease, and can be reviewed by the patient in an unpressured, self-paced manner. Such standardized breast cancer decision tools improve patient understanding of the disease, reduce decisional conflicts, and increase satisfaction. Increased use of decision aids may enable women to make well-informed treatment decisions that are aligned with their personal preferences and goals. But their use may not decrease the use of mastectomy. Jagsy et al. Demonstrate a laudable increase in breast reconstruction. However, disparities still exist in its availability and use. In contrast, there is a subset of women with early-stage breast cancer amenable to breast conservation that pursue bilateral mastectomy with reconstruction. Solutions to improve access to breast reconstruction must be found, while at the same time assuring that we fully communicate the value of surgical choices and minimize what may otherwise be considered overtreatment. And then we must listen to our patients. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.